Good morning and welcome to this interview with Professor Stephan Schueler, who is a leading expert in the field of mechanical circulatory support. He has been the past president of the International Society of Heart-Lung Transplant and works at the Freeman Hospital in Newcastle. He has over 40 chapters in books and has more than 150 publications. Thank you, Dr. Schueler. And could I begin by asking you to define the term short-term mechanical support, and what devices would you suggest we use for short-term mechanical support?
So there's no strict categories in terms of short-term versus mid-term or longer-term, but short-term we normally think about anything between 1 day and maybe 3 weeks. This kind of interval we're talking about for short-term mechanical circulatory support. It varies sometimes this extends into 4 weeks. But everything which doesn't lead to the discharge of the patient when there's something else to be done, that we would regard as being a short-term mechanical device.
And what would be the devices that you usually use to provide such short-term support?
Well, we would use first of all sorts of ECMO systems, VA ECMO, VV ECMO systems, and then obviously the Levatronics biventricular support. We would use even the balloon pump is still regarded as a short-term device, and then you have new devices such as impellers and new kind of one-sided devices which might fall into this category.
In the real world, what do you think are the most common indications for putting a patient on short-term mechanical support? Like, for example, is it post-cardiotomy shock? Is it acute myocardial failure? Or is it just chronic, very sick patients?
Well, it's both. It's both. You have all sorts of acute scenarios which can range from acute respiratory failure to cardiac failure, or a combination of the two. You have collapse for example, in a trauma center where you have a severely injured patient who requires additional surgical procedures, and in order to stabilize the circulation, you need some kind of mechanical circulatory support. This could be a simple heart-lung machine, which again is a short-term device as such. But then again, you have your chronic stages where patient kind of slowly go down and then have a sudden collapse. Then you have your acute myocardial infarction, you have your acute arrhythmias, etc., etc. So all these categories, whenever you have a collapse of your circulation in terms of cardiac or pulmonary circulation, then you might need short-term mechanical circulatory support.
So actually, in the case of short-term support, the intermac profile really doesn't come into play too much. It's just the acute situation that we are faced with, hemodynamic situation.
Yes. Well, the intermax profile was introduced for more chronic, durable devices in order to classify the patient's situation. And for those scenarios we just discussed, the Intermax really doesn't exist. We call it Intermax Class 0,
correct.
But within this Class 0, you have various scenarios which do not really, Intermax does not really apply to this.
But probably many of these patients would be in a profile 2 or profile 1 kind of situation, because they would be in a case of hemodynamic collapse, requiring inotropes.
Absolutely.
And, so would your first line of treatment be an IABP in a lot of situations like post-cardiotomy or acute myocardial infarction?
Well, the intra-aortic balloon pump has come out of fashion,
yes.
Particularly because the cardiologists don't like it anymore. For surgeons, it has been very valuable for the last 25 years. And still is valuable. We'll still use it because it gives you sometimes this little bit of extra mechanical support which you need to stabilize the patient for a few hours, and then the patient can recover from the trauma of the operation of whatever happened to him. So we still use it, but it depends very much on the patient. We always discuss these days, where's this patient going to? Is it just like a post-cardiotomy situation, or is it something more where you have to plan the next 2-3 weeks and maybe longer, i.e. what happens if the patient doesn't recover from that kind of scenario. And then obviously you use other devices, and the intra-aortic balloon pump would not be appropriate.
Do you use it always through the femoral approach, or do you have been using it through the subclavian artery approach too?
I have been using it through the subclavian whenever you have a very calcified situation in your groin vessels, we tend to go for the upper body. We even use it through the aorta directly.
When the chest is open.
When the chest is open. So I think all these kind of scenarios can be addressed with an intra-aortic balloon pump.
Do you always expose the subclavian artery to put a balloon, or can you put it percutaneously?
You can. I personally prefer to do it properly with a cut down, because then I can control the scenario and I put a vascular graft on it. Or if it's the ascending aorta, I do the same thing. I'm not particularly keen on percutaneous insertion of intra-aortic balloons via the subclavian.
As regards ECMO, it's actually one of the extended use of the heart lung machine, if we put it in simple terms.
Yes.
So next step to the ECMO, what would you consider? Supposing it's not feasible to use an ECMO in a particular patient, what is the other devices that you would use for, say you have a 1 month, like the maximum short-term extended period of...
So I think if the VA ECMO system doesn't work for whatever reason, or is not necessary, then obviously today the most recent development has been the introduction of the Impeller range. And there's a range of sizes available, which, from the 2.5 up to now, they have a 5.5, which literally gives you, full cardiac output for literally every patient you're looking at. They become very effective in the cath lab. Cardiologists are using them more frequently now, but we have been using them as well in the surgical setting. And especially when you have a scenario where there's isolated left-sided failure, then the Impeller works very well. So i.e. for those patients who have a more need for maybe a little bit longer than a few days, again, coming back to this idea of doing a cut down the subclavian artery, that's what we normally would do. And we would use now in England, we have the approval for the 5.0 Impeller, and we would use that. The advantage of the Impeller is that it allows the patient to be mobilized, and this is a huge difference. Anybody who works on intensive care knows how difficult it is if you keep a patient in bed for a week. That is a different patient after that end of the week. Right. Whereas if you have an Impeller and the patient can, be extubated or is not even intubated, then the mobilization for the nursing staff, the physios, is much easier, and the patient doesn't lose muscle mass. And in order to get him through rehab will be much easier.
It's something akin to using a subclavian IABP.
Absolutely, yes. You can use it from both sides. Sometimes I prefer the right side if the patient has already intervention, pacemakers, etc. On the left side, I would prefer the right side. And sometimes it's actually quite useful if you have it in your theater setting to have a cardiologist as well, because they're very good with wires. So to introduce sometimes, to place it properly. So this.
Do you require fluoroscopy for putting an Impeller?
Yes.
So in your theater, you have that facility available?
We would use fluoroscopy plus TOE at the same time.
Can it be done with TE alone, with the transesophageal echo, or fluoroscopy?
We haven't done that yet, because most of the patients were intubated anyway. So we then used the TOE in addition to the fluoroscopy. And I think that setting has worked quite well.
If we go one step ahead of the Impeller, and if we do have to use an LVAD in a situation where we don't know, that we think that this may be short term, but actually is going to extend further, maybe the ECMO period is over or the balloon period is over, we still require support, what would you suggest? Moving on to an LVAD if there is a...
Well, at the moment within our community, there's a big debate going on which way to go. And I think this depends very much on your local settings as well. For example, in centers where they have good access to donor hearts, sometimes even urgent transplant is acceptable. What we would do in the UK, where you don't have access to donor hearts on a regular basis, so they're very scarce. So we need to do something else. And then we would consider this patient for a durable device, i.e. an LVAD, which is not an easy decision, because the outcomes are not particularly favorable in comparison to other stable patients. But the bottom line is, if you can save a life, it might be just justifiable. Whereas transplantation is different. I would be more keen to apply a durable device than progress this patient towards transplantation, because transplantation is a very rare commodity.
And
have
of
a
course, you
donor.
may have a reversible situation, which you might be able to
Precisely.
avoid transplantation because it's an acute setting. We
Precisely.
never know which way it goes.
Yes.
So you would.
But the difficulty is sometimes if a patient is on VA ECMO to predict the right ventricular function around an LVAD implantation. So if you do that, you always have to be prepared to put a temporary RVAD in at the same time at the insertion of the LVAD, which is not, some people don't like to do. So you have to have a special setup for RVAD support as well.
I was just looking at the recent publication of the STS database on mechanical circulatory support, and I was surprised to see that associated use of an RVAD with a continuous flow LVAD was just 2.6%.
Yes.
So between the figure 2006 and December 2017, only 2.6% of patients had an associated RVAD.
Yes.
Though RV failure, I think, is a major issue.
It is a major issue, and I think whether you transform a patient from an acute setting into a durable setting, or you have a primary implant of an LVAD, the RV is always an issue around the implantation, and you have to have a clear view within your program what you're going to do if the RV fails. Sometimes it's a poor RV anyway, but sometimes it's the management as well of the RV around the implantation, because sometimes you got air embolism down the right coronary, or you have all sorts of other scenarios within the operating room which kind of push you into the corner to use an RVAD. This has changed though, because we have, for example, in our unit, I have introduced a fairly simple way of providing an RVAD. So the anesthetists on intensive care, they actually have a low threshold in asking us to apply RVADs rather than squeezing the patient too much and hope for recovery.
So what are the objective criteria that you would look at when you are assessing the right ventricle? It's echo, of course, but additionally, would you just look at the CVP or the general condition of the patient, multi-organ dysfunction?
Are you talking in surgery?
Yeah, once you've decided to put an LVAD.
Yes. So in surgery, I think it's fairly simple to discover that the RV is not holding. I'm using the HVAD, and it's very simple to see. You can see when there's not enough flow on the left side.
And increasing pressures.
And you increase inotropes, et cetera, you can't come off bypass, or you're off bypass just, and then you see your flow on the left side decreasing. It's almost always a result of a progressive RV failure. And we have a very low threshold these days in applying a temporary RVAD.
What about your opinion on this technical issue of whether we can do it on or off pump?
RVADs?
Any of them, left LVADs too?
Well, I'm a strict opponent of pump, because I think what you have to remember is all these diseased hearts, they have potential clots sitting somewhere. And when you do it off pump, you will not have no chance to find out whether in the apex of the left ventricle, whether there's any debris, any clots, anything in there. You have no chance. You can just hope for the best. And I don't think it's justified, because having a clot, having a stroke, an early stroke, is such a major incident for the patient. I think to put the patient on bypass for a short period of time, fibrillate the heart, or just let the heart beat, just have a proper look inside into the left ventricle, clean it all out, and then introduce the durable LVAD. It's a much safer situation for any patient.
So regarding excision of trabeculae, technical issues, if I may discuss, are you aggressive in removing the trabeculae, or only what comes across the inflow of the cannula?
Yes, I'm very because I'm always hoping that there might be some kind of recovery as well. If you cut things away, that's it.
That's it.
And there's no need to do that. Most of them, they are fairly dilated anyway. There's enough space. But again, if there are clots, if there's any debris, you want this out. You don't want this in the area, in the range of the cannula of the LVAD.
Now, the issue, like you mentioned, LVAD has not become really safe as yet. I mean, though there's only a 70-80% patients have a readmission in the first year of LVAD implant. Why is it that the development of these pumps is taking so much longer than other pumps actually which are used in the world, not medical? There are no sensors, monitoring is difficult, hemocompatibility issues. So if you look into the future regarding the safety aspect, I think one of the reasons why surgeons are hesitant to implant an LVAD is that, you know, this 80%, especially in a country like India, where readmission and costs, etc., mostly borne by the patient. Patient pays out of pocket. We don't have insurance.
Yes.
So why is it that it is taking such a long time to develop these technologies to make these pumps smarter?
I think there's several issues with this. One aspect is obviously there was no market. It's a huge cost to develop such a pump, and there was a very limited market. They were only used as a bridge. So if you use something only as a bridge in these few heart transplants across the world, none of the bigger companies would invest a big amount of money in this. So only then, when we realized, oh, heart transplantation is not going to work for the majority of patients, there's a big need to treat more heart failure patients in various scenarios, then suddenly people woke up and said, hang on a minute, we need newer pumps, and actually we can have a business here. That's one aspect. Then obviously it's not trivial to connect the pumps to a energy source. So the driveline is still in place. And that's, if you look at the readmission rates, any trial shows you that nearly 50% of the readmissions in the first year are related to driveline problems. So there's little problems, bigger problems. The driveline has to go. This is not a trivial situation. Only recently we have started to implement a new system which might have a good future in the future. But again, there need to be a market, and we need companies to realize that they can actually, their investment pays off, and they have, you know, a future market.
I recall your lecture yesterday where you said there was a very nice Australian pump that you used, and then they went out of market. They couldn't develop it anymore.
You know, if the bigger companies now, they have a bigger portfolio of products. So for them to compensate losses, it's easier. But then again, if you develop in a fairly small market, it is a difficult scenario. And that's, I think, is the explanation why you don't have the similar development as it is in other technical products.
Now, you have been through the entire gamut. I mean, you've got a huge experience. You've seen pulsatile pumps, you've seen centrifugal pumps, axial pumps. What do you think is the best solution for a patient?
I think it's still open question. You know, a lot of people are thinking about that we need to reintroduce some kind of pulsatility, because that's what the body is made like.
Right.
I'm not entirely sure that's the case. I'm not sure we have proven that. There have been some investigations now, scientific projects, where people looked into it, and they found in some areas of the body, obviously pulsatility is a good thing. So I think what you need to have in the future, you have to have a smart pump, a pump which adapts to your needs, not just in terms of the hemodynamic profile, but also in terms of your pulsatility. And I think that's what we need to develop. Also, we need to have pumps who adapt to your daily needs. You know, you're not the same all the time. Your heart adapts in a very smart way to the needs of your body. Yes.
Now, regarding the centrifugal pumps and the axial pumps, if you look at the complication rates, one has got a little more than the other. Like centrifugal pumps might be having more GI complications as compared to axial flow pumps or reverse. So it's very difficult for a surgeon to make a choice apart from the cost factor of what he's going to use, because in a country like India now, for example, the cost of some of the older pumps has come down dramatically, and the latest generation pumps are still extremely expensive. So do you think that it really matters, or it doesn't really?
Well, I kind of agree with you. I think, you know, I was always a strong believer that mainly the management is the key to success. Because if you look at, for example, the anticoagulation protocols we're having at the moment, we have never produced any prospective trials. We have never looked into how much aspirin we have to use. We don't know. I think a lot of things have to do with the management. If you compare the likes for likes amongst the pumps and the patients, I think the results are very similar.
So in the earlier pumps, only aspirin was used, like the pulsatile pumps. And now anticoagulation is a major issue, either for a stroke or for a thromboembolic event.
Yes.
So why, is there any developments on this front?
Nothing at the moment. We have done no trials, which is still lacking. We still need to do those prospective trials, even to define the right aspirin dose. We have not done that.
What about management of the the cardiac valves at the time of surgery? What is your general protocol that you follow for the aortic valve and the tricuspid valve?
So we know that, if you have a leaking aortic valve, can be a major problem if a patient has an LVAD in. So my personal approach is, and we know this from the data available, I have a very low threshold in replacing the aortic valve during LVAD implantation. So if there's anything like moderate aortic regurgitation, this patient will definitely get an aortic valve replacement at the time.
And closure of the valve as such, if there is...
I don't like that.
You don't like that. So even if there are a lot of clots in the left ventricle, does it influence?
Well, I remove them. I remove the clots.
So, what about the tricuspid valve?
It's a good question. So I think I had always been a bit blasé about it, and I thought, well, the tricuspid regurgitation is in most cases it's a result of the dilatation. So if the dilatation comes down, the right ventricle comes down, the tricuspid regurgitation will disappear. But in terms of longer term prospect, I think it is valuable to discuss a trial where you compare tricuspid repair versus non-tricuspid repair in patients who you think will have a deterioration of their RV function in future.
Don't you think that because there's no autoregulation in these pumps, that because of some chronic volume overload in the ventricle because of safety issues, there's going to keep on affecting the tricuspid valve and the leak is not going to really subside with the LVAD?
It could be, but the problem is you have to, whether you do it aggressively or whether you're reluctant to do it, I think the problem is you have to face the situation that around the implant of the LVAD, you'll have more problems. You'll have a higher need of RVAD support, and there will be more need for additional procedures during surgery if you address the tricuspid valve.
Now, a majority of 80% of these patients have got a lead. Many of these patients have an AICD.
Yes.
So does that influence your decision too?
It does, yes.
So if you have a lead
if there's a morphological issue which I can address, I would do that.
I think we are running short of time. The time is about another minute. What about these bioinflammatory markers? Is there any progress on that front, inflammatory markers? For kind of like, there have been a number of studies using the Bayesian model. We heard about it yesterday too, that trauma patients, they can kind of predict patients who are going into multi-organ dysfunction by seeing the crosstalk between various inflammatory markers. In the situation of LVADs, is there any, or the RVAD, is there any such progress in any?
I don't think we have looked at this yet. So I think that's a very interesting development, and I think we should, that sounds very interesting information, so we should address that.
And what about the issue of pulmonary dysfunction and RVADs? If the patient has pulmonary dysfunction, would you be hesitant to use an RVAD?
Pulmonary hypertension?
Pulmonary hypertension or any other sort of pulmonary dysfunction when you are thinking of putting an RVAD?
Well, if the patient is infected, if the patient is infected and he has pneumonia, then obviously you can't have an LVAD at the time. And this is sometimes a really difficult scenario. You sometimes have to go through ECMO to resolve the acute setting of, cardiac failure plus infection. So I would not use an LVAD in patients who are potentially infected. In pulmonary hypertension, a lot of times you have pulmonary hypertension, and actually we think that those patients actually do quite well because the RV is fairly strong and can pull through quite well. So I'm not so much worried about it. But obviously you have to be worried concerning your future strategy. If this patient is a patient for transplantation, then it comes into the discussion when you decide to put an LVAD in the first place.
Thank you, Professor Stephan, for the time that you have spent with us.
Thank you.
And there's been a lot of information for the audience, and thank you very much.
Thank you. Thank you for having me.